Hello, everyone. I want to welcome you all to the HE Academy's Vanguard Symposium. Regarding today's presentation, in a recent editorial in The Lancet, the author said that old age is our future, it is what awaits us, and that older people are our past and our future, guardians of our memory and mirrors of our becoming. People aged 65 and older represent, at this time, about 16% of the population. And as you know, it's a segment of the population that's expected to grow quite substantially to be about 22% of the population by 2040. And the 85 and older population is projected to more than double in that period to almost 15 million people in the United States alone. And we've seen firsthand the vulnerability of this older population during this pandemic, where over 80% of the deaths caused by COVID-19 occurred in those over the age of 65. So this rise in seniors over the age of 65 and our ability to care for them is especially acute when you consider the fact that of the 20,000 plus students enrolling in medical school each year in the United States, just 0.5% end up specializing in geriatric medicine. In fact, in the United States, the number of practicing geriatricians per older adult is expected to be almost halved by 2030 compared to the early 1980s. So we're going in the wrong direction. And this all makes clear that we need to be intentional and strategic about enhancing the care of older adults, not just in this country, but around the world. And so with Atria's focus on healthy aging and disease prevention, it's a perfect time to hear from a renowned expert in the field on the future of geriatric medicine. And we have that renowned expert with us here today. Dr. Sharon Brangman is the Distinguished Professor and the inaugural Chair of Geriatrics at SUNY Upstate Medical University in Syracuse, New York. Before becoming the inaugural chair, she served as the Division Chief of Geriatrics for 20 years. She also serves as the Fellowship Director for Geriatric Medicine, and she directs the Center of Excellence for Alzheimer's Disease, as well as being the medical director of the Transitional Care Unit on the Upstate Community Campus, and the medical director of Greenpoint, the Hertz Senior Living Communities in Syracuse, New York. Dr. Brangman, it's a pleasure to have you here today. Thank you so much for lending your time and expertise, and we're looking forward to this presentation.
Oh, thank you so much for inviting me, David. And this is obviously my favorite subject to talk about. And I am going to start out just by giving an overview of geriatrics, because I still get shocked about how many people don't understand what a geriatrician is and what we do. And then I want to talk about some of the challenges that we are actually dealing with now when we talk about the care of older adults. And as let's see if I can advance this. As David mentioned, we are in a huge projection of growth in older adults. Let's see. We have the first wave of the baby boomers started turning 65 in 2011. And the final wave, those who were born in 1964, will turn 65 in 2019. So we still have a few more years, but we are significantly impacted already by the growing number of older adults and the increase in life expectancy. That's changed a little bit due to COVID, but we are still very much affected by this baby boomer group. Now, the baby boomers have had an impact on just about every aspect of our society, from financial services to housing to transportation. So there's no doubt that their impact on the medical care is significant as well. And as David mentioned, the fastest growing segment of this geriatric population are actually those people who are 85 and older. And the reason why that is so significant, because that's the age group where almost by definition, people are frail, they need more medical resources, and they often need help getting through the day. So those are the people that actually use the most healthcare resources. Now, who needs to see a geriatrician? Well, the definition of being older, being set at 65 years, was arbitrarily set about a generation or two ago, and it was primarily for employment reasons. They needed older people to step aside so that younger people could take those jobs. And in those days, those jobs were mostly physical labor, required a lot of body strength, and people were pretty beat up by the time they were 65 years old. But now, if we fast forward now, a 65-year-old in general doesn't need a geriatrician unless they've started to have an accumulation of chronic disease. So we have kind of worked out in the field that the average person who needs to see a geriatrician is usually the ones who are in that most frail group. And that's about 30% of older adults. They're 85 and older. They usually have some level of functional impairment or need some help getting through the day. They often have a lot of comorbidities. They're very complex patients. And those are the ones who have a very long problem list, a very long list of medications. They have geriatric syndromes that I'm going to talk a little bit more about. And there often are concerns about the appropriate level of care. Can they remain independent? Do they need someone to come into their home, or do they need to leave their homes and live in another setting? So this is where the sweet spot is in geriatrics and where we really spend most of our time. So when we look at what is considered a treatment excess in traditional medicine, it usually involves doing some tests, making some interventions, and prescribing medications. But treatment success, when we're talking about geriatrics, has so many other points and quality indicators. So we have to figure out what's an age-appropriate expectation. You know, we can say that you're 65 and older and you need a geriatrician, but someone who's 90 has totally different needs than somebody who's 70. And I always tell my colleagues, if you're in pediatrics, you wouldn't have the same approach with someone who's 1 year old and somebody who's 18 years old, even though they are all within the scope of pediatric care. And so we have to figure out what makes sense for that person, given their age and their other medical problems. We also have to identify the problem, and I'm going to talk a little bit about geriatric syndromes that can be a challenge because the diseases that we deal with often aren't discrete and limited to one organ system. We have a lot of collaborators that we use in geriatrics. We usually have members of our team that include physical therapists, speech therapists. We have nurses, we have pharmacists and social workers. So we have a lot of collaborators as well as other specialties in medicine or surgery. We have to look at the quality of life of the person and what really makes sense for them and what do they want, what do they value in their care. That you can't make a diagnosis or a treatment plan without taking that into consideration. And of course, we have to assess somebody's cognitive skills and function, as well as their mood, if there's any mood or affective disorders. We have to factor in the impact of comorbidities and what their social supports are, who can they lean on in terms of family. And I'm going to talk a little bit about orphan older adults, which are a growing population. And then we have to figure out the appropriate site for this care. Can this be managed in the home or in the hospital? Can this be managed in the office? And what's the difference between assisted living and nursing home in terms of what kind of care we can provide in those settings? We have to prevent iatrogenesis, and there's been a lot of research about what we actually do to older people when we admit them to the hospital, we put them in bed, we wake them up all night to check vital signs and labs and make them delirious, and then they can't go back home to where they were. We have to make sure we are not adding to their their burden of illness. And what is ethically appropriate? What makes sense based on that patient's age, their function, cognition, and other medical problems. Now, in medical school, I was taught a very traditional way to make a diagnosis. If we look at somebody, for example, who has cortisol excess, we know that's a specific process, and it has multiple ways that it can present itself. You might have a moon facies, a buffalo hump, truncal obesity, thin skin, and you may be bruising very easily. So we know that as a discrete entity. However, when we are talking about geriatrics, it's really quite the opposite. We have multiple morbidities and processes that are going on that can lead to a specific phenomenology that we look at and see that person. So if we look at someone who has delirium, we know that is in a risk factor for someone who has dementia, or if they're dehydrated, if they're septic, if they can't see or hear. And often if somebody comes to the hospital, they quickly get separated from their hearing aids or their eyeglasses. We have to look at side effects from medications and sleep disturbance. So there are so many different things that go into one specific syndrome. So this is a list of the geriatric syndromes, and there's a lot of debate if there should even be more on this list. Frailty was recently added, dementia, depression, delirium, falls, incontinence, polypharmacy. And the things about the geriatric syndromes is that they're highly prevalent, they're multifactorial, they're associated with substantial morbidity and mortality and poor outcomes. And the complexity is added due to underlying factors and the involvement of more than one organ system. So it doesn't have the usual disease boundaries that happens when you are looking at one organ system. They don't fit into nice, discrete disease categories, and they overlap with many different conditions. They're common, especially in frail elders, and frail elders have reduced physiological capacity to respond when they're stressed, and so they have especially poor outcomes. And they have an impact on quality of life and functional status. So the challenge is that the traditional ways that we were taught to make a diagnosis don't really work with the geriatric syndromes because they often involve more than one specialty and more than one organ system. So if we look at falls, for example, falls is one of the biggest syndromes that I deal with, maybe next to dementia, and falls really can change an older adult's life. So if we have a patient who has, for example, dependent edema, which is not really a disease state, but a lot of people see swollen ankles and they have kind of venous insufficiency just from aging, and they might go and get a diuretic. And then that diuretic gives them urinary frequency and maybe incontinence. And then they're not sleeping very well. And then because they're on a diuretic, which can lower your potassium level, we prescribe potassium. And they're getting up and they're going to the bathroom. So then the doctor thinks that maybe they have a bladder spasm. So then they need a medication to help with their bladder. And so we end up with polypharmacy. And they can't see very well when they get up. And then they don't want to drink a lot of fluids because they don't want to have to urinate more. So you can see how you can end up with a fall that's based on multiple factors. And this adds to the complexity of the care that we have to give as geriatricians. So if we have an 88-year-old woman who comes in with fatigue, confusion, and a recent fall, what is the most likely diagnosis? Is it A, Alzheimer's disease? Is it B, a myocardial infarction? C, a UTI? Or is it D, an upper GI bleed? And the answer is really all of the above. So frequently we see a disconnection between the complaint that the patient has and the underlying condition. So a lot of the diagnoses we make are very atypical. So for example, an older adult who presents with a urinary tract infection, the only indication of something going on may be a change in her mental status. So she may present with delirium. So the cognitive and behavioral changes we see are really based on an infection. And if you don't have the skill set to help dig a little deeper and figure out what's going on, you can totally miss the diagnosis and not give that person the care that they need. The other thing that we do as geriatricians is that we have to do a functional assessment. We have to know how that patient takes care of their needs and gets through the day, because that impacts anything that we're going to do in terms of setting up a care plan. And so there are two categories of activities of daily living. There are the basic ones, and those include dressing, eating, ambulating, and toileting, and hygiene. And then we have the instrumental activities of daily living. And these are usually the first ones to decline in somebody who has any memory problems or cognitive impairment. And these include accounting, taking care of your household, keeping track of medications and appointments. For some reason, it's not all lining up here. And so if somebody can't do their instrumental activities of daily living, they can usually buy services and have someone come in and help, or they may be eligible for assisted living. But if you can't do your basic activities of daily living, then you likely will need 24-hour care, or you could even need to be in a nursing home or that care in your home. So we have to be able to figure out which one they have. And now somehow it's now loading. So you can see, and those of you who like mnemonics, you can see what the mnemonics end up for the basic activities of daily living. For people who can't do those, the mnemonic there is death. And for the instrumental, it's shaft, because they kind of get the shaft because they need some help getting through the day. The other thing that makes geriatrics distinctive is that we always deal with caregivers. And this is where we kind of line up with pediatricians who always have parents that they're taking care of. But in geriatrics, our caregivers could be a spouse or a partner who could be the same age and have just as many medical problems, or it could be an adult child who may or may not even live nearby, which creates another set of problems, or an adult child who is trying to work full-time and raise their family. We need to get history sometimes to corroborate what's going on. So we end up with more than one patient. We may have somebody who's officially registered in our office, but then we have a caregiver who is just as critical to the well-being of that person. And so we have to screen that caregiver to see how stressed they are, how adept or able they are to provide the care that the patient needs. And even if they have the best of intentions, can they really carry that all out? So we really can't get by without caregivers. And caregivers actually save the government billions of dollars by giving informal care, often to their own detriment. It's often a woman and an adult daughter, although I've seen a lot of sons step up. They sometimes have to stop working or cut back on working, which has financial impacts. And it really can be a huge financial burden. Many of the caregivers are very surprised to learn that Medicare does not cover that kind of care, personal care or home care. There's a rising group of what has been dubbed orphan elders. And these are people who are the last remaining person in their family, or maybe it's someone who never got married, never had children, don't have any other relatives. And as they age, they do not have that caregiver support system in place. And so we have to figure out how to help them get that support when those caregivers who are giving so much care normally aren't around. And this means that somebody needs to help with finances, so you need a trusted person to do that, but also personal care, deciding when somebody needs a higher level of care. These are all important factors that come into play and can be a huge challenge when there are no family members around. The other thing we do in geriatrics routinely is deal with advanced care planning. Who is the healthcare proxy? Who is going to help that older adult make decisions if they can't make them on their own? Do they have a living will? Do they have those forms filled out? And we get called a lot to help determine if somebody has the capacity to even make these decisions. So we have to assess someone to see if the healthcare proxy needs to step in and help, or if that older adult is able to make decisions on their own. This is a very time-consuming process, and you have to know the person well. Sometimes you can't even make these determinations on one visit. And only recently did Medicare start to reimburse for advanced care planning and completing these forms. They used to not be reimbursed at all. That kind of ties into the second part of what I'm going to discuss this afternoon. A natural fit for what we do in geriatrics is deal with end-of-life care and palliative care. And palliative care can be applied to any age person, but clearly it does become an important factor in how we plan care for older adults who have multiple chronic illnesses that can't be cured, but still need care. And at what point do we say we're going to make sure that they're not getting any more diagnostic tests or blood work or other things that are not going to change the outcome, but just increase that burden to the person. So we have to have conversations with families to help them understand the limits of treatment. What is the efficacy of feeding tubes and feeding someone parentally? They make it look so easy, but it is not really good for most older adults, especially older adults with advanced Alzheimer's disease. Do transfusions make sense? At some point, does dialysis still make sense, or surgery? These are very individual-based decisions, and it depends on what is happening with that person and what their comorbidities are and what their preferences are. So we have to have a lot of in-depth discussions to understand what their goals of care and what they want. I talked a little bit about the team approach, and I think that geriatrics really led the way for developing the team, but now they're très chic to have teams for cancer, there's teams for strokes, but we really knew from the beginning when geriatrics was just formulating that it's not a doc working by his or herself to take care of the patient. We have nurses all the way from an LPN to a nurse practitioner, physician's assistants, home aides, social worker, case manager. Pharmacist is so important, especially with all the polypharmacy and the drug-drug interactions, geri-psych. And probably the thing that's more rare than a geriatrician is a geri-psychiatrist, because there are just so few of them and the need is so great. The thing to understand about the team approach is that when we are practicing, these are not usually people who can bill for their services, with the exception of maybe the physician assistant and the nurse practitioner. We often have to figure out ways to reimburse for this important aspect of their care, and that presents a special challenge. The other thing that is distinctive about geriatrics is that we are experts in providing care in the appropriate setting. And many of us have expertise not only in taking care of patients in the home or in the office, but also in the nursing home, as well as the hospital, and knowing the difference between assisted living and nursing home. So, for example, many adult children who are looking at placement for their parents like an assisted living because they tend to look more homey, they have living room furniture and potted plants, but they don't usually have a nurse on duty. If they have a nurse, the nurse is often in an administrative role, but not really there to do assessments. So if you have a frail person in assisted living and something happens to them, they have to go to the emergency room to get assessed. And so we have frail people who bounce back and forth to the emergency room because there are no health providers on site. A nursing home, on the other hand, is a medical model which does have nursing home, that does have nurses available to do assessments and can do, depending on the facility, IVs, antibiotics, x-rays and other things, so you may reduce the amount of transfers to the hospital. And families don't understand this, and they're trying to make a decision, and we have to see where that person, that loved one, would get the most appropriate care. Another very time-consuming conversation, but very, very important to help families identify the right level of care. So if we look at traditional medicine versus geriatric medicine, traditional medicine is focused on a cure, whereas in geriatrics, we are generally not curing anyone unless maybe they have a simple urinary tract infection or a simple pneumonia, but we're mostly taking care of somebody who has multiple medical problems that are probably going to get worse with time. Traditional medicine is looking at that disease and that organ system. It uses an organ-based model to make a diagnosis. But in geriatrics, as I mentioned with the geriatric syndromes, we have to manage multiple diseases and conditions that really cross over into various organ systems, and it all depends on the functional status of the patient. Is that patient able to get on and off the toilet, walk, stand, and cook a meal? If they can't do that, then we have to start thinking about what other supports and services they need. Traditional medicine has always kind of been the solo, although there is more and more team-based care even in traditional medicine, but geriatrics has always been the team approach, as I mentioned. So we've always worked with other health professionals, which really emphasizes the importance of interprofessional collaboration and education. So the key things to take away from this first part is that aging is not a disease, and it's something we all aspire to, considering the alternative. But every person has a unique way of processing the aging process, and we have to be able to look at that person and see what makes sense for them. Medicine has really evolved into algorithms where you have all these decision trees and you're just supposed to follow them. But it really takes away from what's happening to that individual person. So for example, I had a 94-year-old patient who was playing cards in his assisted living facility one day, and somebody noticed he had a little bit of a facial droop and thought he might be having a TIA. So he got whisked away to the emergency room. And by the time he got there, his face was symmetrical and there was no evidence of any droop. However, because we are a stroke hospital, we have a protocol, and he was immediately put into that protocol, which required angiographies and MRIs and all of this testing. And we were trying to stop that testing because of his age, if we found something, he would not benefit from an intervention. And all he wanted to do was go back and finish his card game. He ended up getting admitted, and then of course he's put in a hospital bed and he gets weaker. And then the whole decision was made, could he really go back to assisted living? Because now we have to make sure he can walk. So we took somebody who had an acute illness. We didn't really look at their unique situation and really what mattered to this patient. And we immediately put him through a stroke protocol that really didn't help him at all. So that is part of the skill set, is figuring out what makes sense for that person at the right time, the right location. And it's really a shift in our diagnostic skills. We still have the ability to make these diagnoses, but we have to look at them a little differently because we have to take that person's age, functional status, and really what their goals of care are into consideration. So we've kind of been nicknamed the complexivists. You've heard of intensivists who work in the ICU. Well, geriatricians have been called complexivists because of the complexity of the decisions we have to make, the advanced age of our patients, their medical problems, their medications, their functional status, and really what they want done. We have to consider the geriatric syndromes and atypical presentations and really what matters most to our patients. I always tell the students who rotate with us that you can follow an algorithm and do everything to everyone all the time and follow that algorithm. And you may be in compliance with that algorithm, but are we really giving thoughtful, appropriate care? I would argue that it actually takes more skills and time to figure out if that algorithm is really going to help that patient get the most appropriate care and have the best outcome. So David mentioned some of the challenges with the geriatrics workforce during his introduction. And when I was preparing for this talk, I looked back 20 years and I realized we've been having this discussion for at least 20 years. So in 2021, there was 7,123 certified geriatricians. By 2025, which isn't that far off, there's only going to be 6,230. That's about one for every 3,000 older adults. A shortage of about 27,000 geriatricians, and we're already feeling it. We already see that many certified geriatricians are not sitting for the boards to get recertified, and we have fewer and fewer students picking geriatrics as a career option. And it's not just geriatricians. About 1/3 of older adults are seen by PAs, and only about 1% of them specialize in geriatrics, and their curriculum often doesn't even include geriatrics when they're training. That's similar for registered nurses, for pharmacists. There's only about 4% of social workers who specialize in geriatrics. And we have certainly seen with the pandemic a shortage of direct care workers. I have almost daily conversations with adult children who want to keep their parents at home, but they can't find home health aides. And I also know of nursing homes that have closed off units because they don't have enough nurses to staff a nursing home. So we have significant problems going on. You don't hear it discussed very much, but we have significant shortage of direct care workers, which has immediate impact on the care that older adults can receive. And there are many reasons for this. I'm going to talk about one of the biggest ones, and I think that's ageism. And that's discrimination that's based on age, especially prejudice against the elderly. It is the one ism that we will all share and experience if we live long enough. And one of my colleagues, Laura Mosqueda, who was a former dean at UC Davis, she's a geriatrician, she says, ageism is discrimination against our future selves. So anyone who's participating in it is really looking at what will happen to them in the future. And this has been a big issue. Robert Butler, who is one of the major leaders in early geriatrics, says a lot of this has to do with our fear of dying. The underlying basis of ageism is the dream and fear of growing older, becoming ill independent, and approaching death. People are afraid, and that leads to profound ambivalence. It is ground into our culture. It is part of every institution in our culture. And I just grabbed some marketing materials that advertisements were made. And there was a lot of talk when John McCain was alive and his appropriateness. We have leaders of our country right now who they're trying to decide if they should run for office again because of their age. So we have this mindset that once you're a certain age, your usefulness is pretty limited. And we really worship the Pepsi generation. If you're old enough to remember the Pepsi generation, those were carefree young people walking on the beach, having a wonderful time. Those are the people who we think are important. And if you remember in the early days of the pandemic, Lieutenant Governor Dan Patrick from Texas actually said he thinks that older adults should take a chance. And if they die, they're doing it for the sake of their grandchildren and the economy. My patients heard this and they were terrified. They already knew that older people were dying in droves because of COVID. And then when they heard government leaders essentially writing them off, my patients were not, they didn't have to be convinced to stay home and or to get vaccinated when it was available. And then there was a big controversy in New York State when the governor at that time, Andrew Cuomo, had ordered nursing homes to accept patients from the hospital who had COVID. And that essentially blew up the nursing homes and people died in droves because nursing homes have roommates. For most part, most of the beds are set up with roommates. And as soon as there was one roommate who was sick, it went through the entire facility. There was very limited PPE being given to nursing homes. And you have frontline staff who often were taking public transportation to work so that they were then spreading it and catching it themselves. I think one of the reasons we have such a shortage of home health aides is because so many of them died, especially during the first wave of COVID. But you see here two leaders who essentially wrote off older people during a pandemic. And that message was heard loud and clear by older adults. I don't know how many middle-age adults heard it, but they should be concerned too if this is what the value society places on us as we age. You may have heard of Ezekiel Emanuel. He has a famous brother, and he is an oncologist and a bioethicist, and he wrote an article in The Atlantic back in 2014 that says he hopes to die at 75. And he's made a vow that after age 75, he's not going to get any screening tests, no labs. He may not even take antibiotics because he believes at age 75, you have no more value to society. Your creativity and your work days are over, and you become a burden, and you essentially suck resources out of our society and don't give any in return. So here's a well-educated, influential, powerful person with these kind of sentiments. And I say, why stop at 75? I know some 55-year-olds with chronic diseases and disability. Maybe they're sucking the life out of our society. So maybe we should be thinking about not working them up if they get pneumonia and not giving them an antibiotic. So this becomes a very slippery slope, and giving our health systems history with people who are not deemed worthy or all the disparities that we have, it makes it a very scary proposition for people to think that you have no value after a certain age and you should probably just roll over and die. So ageism has actual consequences, and this was taken from the Alliance for Aging Research back in 2003. And it comes in many different shades. Healthcare professionals do not get sufficient training in geriatrics. Older adults are the patients nobody really knows in healthcare. And they are increasingly in every specialty except for pediatrics, but it's not in the curriculum uniformly in schools. They're less likely to receive vaccines and other preventive care. They're less likely to be tested or screened for common health problems. And effective medical interventions that are beneficial are often ignored. They may not get a cardiac cath, even though that's the standard of care, because they're considered too old. And this may happen without even asking them what their values are and what matters to them. And something that I've been spending a lot of time with lately is the exclusion of older adults from clinical trials. Even though they're the largest users of most medications and devices, most clinical trials don't even include older adults. So we are left to kind of extrapolate and hope that the drug we're prescribing is going to be helpful for somebody, even though the cutoff for the study was at 50. And I'm taking care of an 88-year-old, and I'm trying to figure out if this is a medication that might be helpful. There's no other age group that would be considered acceptable. The other big issue facing geriatrics is the lack of a primary care pipeline. Primary care is really essential to a healthy, coordinated healthcare system, but it is underpriced by Medicare. Any specialty that is considered a cognitive specialty, where you are thinking and planning and balancing a lot of information, is really undervalued by Medicare. And so the majority of internal medicine residents specialize. They know that interventional cardiologists, pulmonologists, and gastroenterologists, at least for the time being, are reimbursed at much higher rates than a primary care doc. But if you don't have a good primary care doc, that creates a more expensive healthcare system. And then you do not have somebody who's coordinating that care. And that is not good for the patient, and it's not good for the healthcare spending bill. And then in the late 1990s or early 2000s, hospital medicine became a significant specialty. And so many residents chose to become hospitalists because it was really very much like the job that they were currently doing, except they could get planned time off. And they were making very good, even to this day, they make very good money the first year out of residency. So that is another specialty that has siphoned away primary care docs, which then siphons away geriatricians, because geriatricians tend to come from the primary care pipeline. And for most of you may know that you can enter geriatrics either through general internal medicine or family medicine. And those are both primary care specialties. Family medicine also has had a significant decrease in people picking their specialty. So the challenges for geriatrics are very real. I was on the admissions committee for my medical school for over 30 years, and I would read so many essays from undergrads talking about their relationship with their grandparents and how they volunteered in a nursing home and how that they really like older people and they hope to be able to provide care for someone like their grandparents. However, by the time they rotate through the hospital, we have a very efficient socialization system that really turns med students and residents off to any complex patients, and especially older adults. I think that there's that need for quick solutions so that people can get through their day and their workload, and you need to spend time, I would argue, with all of our patients, but especially older ones. Geriatrics is not consistently in the curriculum in many med schools. There was a big push in the late 1990s, early 2000s, but as curriculums get updated, often geriatrics is not in there. So therefore, med students are not learning geriatrics, residents, surgical subspecialists, geriatric fellows, they are the only ones getting concentrated curriculum in geriatrics. And if you look at the average internal medicine resident, they are practicing on older adults. Who is coming in for cardiac care? Who is in the ICU? Who has GI problems? Who's getting the GI bleeds? Who has cancer? Who has pneumonia? So they're taking care of older people without getting the proper instruction in their curriculum to do so. And then there's the financial piece. And this one, I think, is really up there with ageism as two big deterrents to geriatrics. So if you look at the cost of medical education and the amount of debt that students and then residents are graduating with, they are looking for a business proposition to pay off their debts. I recently was talking to a med student who loved geriatrics from day one. She took every elective we had. She was seeking out extra experience in geriatrics. And as I was talking to her, she had taken time off to become a dietitian at Columbia with a huge, huge loan to do that. And then she had so much debt from med school and living expenses. She was a third-year med student who already owed $500,000, and she did not think she could be able to afford it. She is now a radiation oncologist, and that is the truth of it. There are salary limitations. Geriatrics is the only fellowship that after you complete it, you actually make less money than a primary care internist. So how does that make sense? And then how does that help you recruit? So we have geriatricians who have very high degree of job satisfaction and they love what they do because they do it despite these limitations. What we really need now are people who see geriatrics as a reasonable living. I don't think every interventional cardiologist loves interventional cardiology. They just see that as a job that gives them a reasonable living. And then we have Medicare. Medicare is the primary payer in geriatrics, and they regularly cut physician services. So this year they were going to do an 8% cut, but it got pared down to 2%. And this is interesting because there are anti-amyloid drugs in the pipeline. You might have heard of some of them getting approved for people with early Alzheimer's disease. And these drugs are going to cost, say, about $30,000 a year, and a lot of physician time to monitor them. So we have to monitor very carefully for side effects for these medications. Medicare is going to pay the full bill. They haven't said so yet, but I'm pretty sure they are going to pay the full bill because they increased the Medicare premiums last year in anticipation of these expensive drugs getting approved. So they're going to pay the full bill for these drugs that have modest, at best, impact on people with Alzheimer's disease. But the doctors who are going to be managing their care are going to get a 2% cut. So tell me why that's logical, and tell me how I make that argument to a resident who owes $300,000, $400,000, $500,000 that geriatrics is a good specialty for you financially. The other piece is the way the fellowship programs are set up. Right now, there are more fellowship slots than there are applicants, and this has been true for more than 10, 15 years now. Geriatrics also has a very high number of international medical applicants, and this creates a problem because many of them have visa issues. So after they finish training, you have to support their visa in order for them to stay in the United States. That's a very expensive proposition, and it is very bureaucratic. It can be a very slow process, and we lose a lot of people in the interim because there's just been a slowing of processing of visa applications. And as I mentioned earlier, geriatrics is the only fellowship where your salary goes down after training. I've had colleagues that have helped forge loan forgiveness programs. There's some in New York. I know my colleague in South Carolina did one, but that hasn't had the intended impact because by the time somebody is looking at loan forgiveness, they've already selected their specialty and they're already trying to figure out where they're going to live. And so they're not going to pick a state and a specialty at that point. It's a little too late for that to be effective. This is a little colorful graph that shows the results from the match program from this past year. And on the left at 100% is cardiology that totally filled all of its slots. And on the right at 33% is geriatrics, which only filled 33% of its slots. And the other important piece here is in the middle are a lot of pediatric subspecialties that also didn't fill. So I think if we're looking at the two vulnerable populations in our country, which are children and older adults, I think there's some parallels in workforce issues, because I have colleagues who are telling me that there are very few people doing general pediatrics. And from the results of the match here, it looks like they're having trouble with even specialty pediatrics. So we have more slots than we have applicants for geriatric fellowships, and each year the programs do not fill. And these are programs that are brand name, Ivy League, big city, as well as community-based programs in smaller or middle-sized cities. They're all having the same problem. So to look at solutions, another colleague, Mary Tinetti, who's at Yale, came up with this big G, little g approach. She doesn't think that we need to spend any more time trying to convince people to go into geriatrics, because all of our efforts still yield the same number of people. But instead, we should look at the big G, which are the certified geriatricians who become like an elite workforce, who lead research and discovery, professional and public education and public policy. And the big G geriatricians help to get the little g geriatricians to learn geriatrics for their specialty, incorporating that with the guidance of the big G geriatricians into their curriculum and into their algorithms and standards of care. And there has been some success to this approach. There are a number of initiatives that have been in place. There's the Geriatrics for Specialists initiatives, which I think is about 20 years old, with the American Geriatric Society, which has been working with surgeons and subspecialty surgeons, as well as other subspecialists in internal medicine, to add geriatric content to their training. There's the Geriatrics Workforce Enhancement Program that has been sponsored by HRSA, and they have literally put billions of dollars in to try to train all members of the geriatric team in geriatrics. So for social workers, all the whole team, nurses, etc. And then there's the Geriatrics Academic Career Awards for people who want to increase their skill set in geriatrics. There also are a number of specialties that, with additional training, have incorporated geriatrics into their specialty. So now you can be a hyphenated general surgeon who does geriatrics, the same with emergency medicine, and there's also geriatric hospitalists. So this is a way of getting other specialists to get some skills in geriatrics so they can hopefully do the majority of the care, and then the more complex issues can then be managed by the elite big G geriatricians, because we clearly can't see every patient. And then there have been a number of models of care where geriatric principles have been expanded into systems to provide better care. And these systems are not necessarily led by geriatricians. You might have heard of the Hospital Elder Life Program, or HELP, which helps hospitals improve their care for older adults. And it is teaching people across specialties who are not geriatricians to do this. There's the acute care for the elderly, or ACE teams and ACE units. And in many cases, these are not led by geriatricians, but other doctors and nurses are learning geriatric principles so they can take better care of their patients. The American Geriatric Society has really led the way with the Ortho Co-Care program. We recently opened up a site in our hospital where we train emergency room docs, orthopedic surgeons, operating room anesthesia, nurses, etc., in some of the geriatric principles so they can take better care of older adults who have hip fractures. And it has been shown to improve the care, reduce length of stay, and reduce bad outcomes. There are a number of people looking at home-based primary care with geriatric principles. You might have heard of the Program for All-Inclusive Care of the Elderly, which is a kind of like a day program nursing home where people come to a medical day program during the day and then go home at night. So they get their care in the day, and much of that care is not given by geriatricians because there's just not enough to do it. But geriatric principles are built into the model. And then one of the newest entries has been the geriatric emergency room. Some of them are called Gem Care, where they look at ways of making emergency rooms and emergency room physicians more knowledgeable in geriatrics so they can take better care of older adults when they come into the emergency room. So these are all models of care where geriatric principles can be expanded and carried out without the big G geriatricians. So just to summarize here, and then I'm going to open it up for discussion. We have had long-standing issues with the healthcare workforce. The healthcare workforce is losing people regularly who are interested in doing geriatrics. And I don't see a big change in the future. So I think the approach of the big G, little g, where we integrate geriatric principles into medical and surgical specialties are going to be the way to go. I still think we need to get medical schools and nursing schools and physical therapy programs to increase geriatrics in their curriculum. So you can get the big G workforce to help build that curriculum so that all health professionals are learning geriatric principles. So for example, in medical school, you have a required rotation in obstetrics, but very few people end up delivering babies. But just about every medical school graduate is going to take care of older adults unless they are pediatricians. And then I tell my pediatric colleagues, you're going to be dealing with grandparents who are raising their grandchildren. So you still may need to know some geriatrics. And then a lot of my friends who tell me, oh, I'm so glad you're in geriatrics so you can take care of me. And I'm like, I'm not sure that will work because we're the same age. So I tell them the best thing is to stay young and stay healthy.
Thank you so much for
Thank you.
this wonderful presentation. Thank you for being on our academy. We're proud and honored to have you, and we'll look forward to your next presentation, which hopefully will be later this year.